Welcome, everybody. We are excited to have you here for Echo Autism and Applied Behavior Analysis, and are excited for our clinic today. We have Dr. Brian Lopez that will be joining us today for the second training in documenting medically necessary treatment, and he's also joining us today with one of his BCBAs, Molly. They will be co-presenting a case from their practice today in which they will be discussing complex case, reviewing the primary concerns, and then walking us through the treatment, how they addressed and assessed the different treatment barriers and the outcomes. We're excited to learn from their case today, and this is going to be a great discussion that we're hoping everybody will become involved with. They are open for questions and to allow us to learn from them and the case. We then will have another clinician that will be presenting an abbreviated case in which she'll be discussing the medical review process and sharing with us how she has had to present a case and identify and document medical necessity with a clinical team with an insurance company. She'll be sharing the rationale behind why the case went under review and the questions that they asked. So for those of you that have not gone through that process yet, we would love for you to be able to ask questions to learn from clinicians that have. And those of you that have gone through the process, we would also love to hear your feedback in what that process has looked like, what information you have shared, and the outcomes as well. So before we get started, we'll go ahead and go through and do some brief introductions with our panel, and then we'll go through introductions with our participants in the audience. So I'll begin. My name is Dr. Joy Pollard. I'm a board-certified behavior analyst, and I am working here in Oakland, California, as a facilitator of autism. Kathleen?
Hello, my name is Kathleen Karamy. I'm a healthcare administrator also here in Oakland, California, and I'm a HUB panelist.
Wonderful, thank you. Haley?
Hi, I'm Haley, and I am the clinic coordinator, so I'll be managing the chat box. I also put my phone number if you have any questions throughout technical difficulties. The one thing that I ask is that you can put your full name as opposed to a username so that I can make sure that I mark you as present.
Thank you. And Zoe?
Hi, my name is Zoe Miguel, and I'm here in Santa Fe, New Mexico. I'm the Executive Director of Bright Futures, Autism and Early Intervention, and I am a HUB panelist.
Thank you, Zoe. And we have Sarah Baca.
Hi, I'm Sarah Baca, and I am a parent to an 8-year-old child, Preston, who happens to have autism, and I am also the director of Mexico Autism Society.
Wonderful. Thank you, Sarah. And we have Tina Goldsmith.
Hi, everybody. I'm Tina Goldsmith. I'm a licensed clinical psychologist and a doctoral level board-certified behavior analyst, and I'm joining from Los Alamos, and I serve as the director of training for Trumpet Behavioral Health, and I'm a HUB panelist member.
Thank you so much. All right, I'm going to go ahead and go through and unmute you, and if you could identify that would be wonderful. If you do have any difficulty with the audio, please feel free to go ahead and chat into the chat box. We have Arlette.
Hi, good morning, everybody. My name is Arlette Bujanda, and I am an associate clinician with Behavior Change Institute in El Paso.
Thank you. And Dr. Lopez and Molly, would you like to introduce yourselves?
Sure. I'm Brian Lopez. I'm a clinical psychologist and the executive director of Jumpstart Autism Center. I specialize in the treatment and diagnosis of children with autism.
Great. Wonderful. Thank you.
And I'm Molly Boxall. I'm a board-certified behavior analyst that works here at Jumpstart Autism Center.
Welcome. Thank you for joining us, Molly. We also have Carly Chapa.
Hi, I'm Carly. I work with Behavior Change Institute. I'm a board-certified behavior analyst. I am in Albuquerque, New Mexico.
Thank you. Jennifer Chavez, I see you're on the line. I'm not able to unmute you, but if you're able to chat in, please do so, and welcome. We also have Claudia.
Hello.
Hi, Claudia. Do you want to introduce yourself?
Yes. I'm Claudia Goswitz. I'm in San Antonio, Texas, and I am the clinical director of a comprehensive center for autism services.
Wonderful. Welcome, Claudia. Okay, and we have C. Montanez.
Yes, hi, I'm Cosette Montañez. I'm a clinical psychologist and I'm with Las Cruces Public Schools.
Wonderful. Well, welcome. It's great to have you here. David Picard.
Hi, I own and operate a small clinic in Montgomery, Alabama.
Wonderful. Thank you so much for joining us, David. Okay, and we have an EC Fair. Okay.
Hello, I'm here. Here.
Okay, great. Would you like to introduce yourself?
I'm the administrator for Integrated Therapy Services in Camarillo, California.
Wonderful. Thank you so much for joining us today.
I'm recording this session for our therapists who are seeing clients, unfortunately, at this time. So hopefully this will be available for them to view at a later time.
Yes, we are recording and we actually have a video archive on the website and upload all the videos as well as presentation materials for our participants and anybody who is unable to participate to access later.
Okay, very good.
We'll include the link in the chat box for you as well.
All right, very good. Sounds good.
Thank you. And we have Farah.
Hi everyone, my name is Farah Sagata. I'm in Albuquerque, New Mexico. I work with Behavior Change Institute and I'm a BCBA intern.
Wonderful. Thank you, Farah. Jolie.
Hi everyone, I'm Jolie. I work at Behavior Change Institute as an RBT and I'm also a BCBA intern and I live in Washington State.
Great. Thank you, Jolie. Kari.
I am Kari Hoskins. I work for Behavior Change Institute as a senior clinician and director of training, and I'm in Lubbock, Texas.
Thank you, Kari. We have Carla Durig.
Hi everyone, I'm Carla Durig. I am currently working with Behavior Change Institute as an RBT in El Paso, Texas, and I am a newly certified BCABA.
Great, thank you, and congratulations. We also have Caitlin.
Hi, my name is Caitlin Mullen. I am the Director of ABA Services for the Midwest region of SkillSprout.
Great. Welcome, Caitlin. Thank you. We also have Kathleen McClelland.
Hi, my name is Kate. I'm an RBT in Roswell, New Mexico, and I'm currently in BCI's internship program.
Great. Thank you, Kate. Liz?
Good morning, I'm Liz Sepulveda. I am also a registered behavior technician for Behavior Change Institute in El Paso, and I too am a newly certified BCABA.
Yes, and congratulations to you as well.
Thank you.
Toba.
Hi everyone, can you hear me?
We sure can.
Oh, hi everyone, my name is Topa Augustine and I am out of Mexico. I'm a consultant and right now I'm working with Bernalillo Academy and I'm happy to be here.
Wonderful, welcome Topa. It's great to have you.
Thank you.
Monica?
Hello everyone, my name is Monica Mejia and I am a BCBA and senior clinician at BCI and I am currently joining from Bogota, Colombia.
The wonders of technology. Nicholas.
Hello, everybody. My name is Nick Orland. I'm a BCBA at BCI, and I'm from Massachusetts.
Thank you. Patty?
Hi, I'm Patty Farrar, and I'm from Puerto Rico, BCBA.
Wonderful. Well, welcome, Patty. It's great to have you today.
Thank you.
Sarah Bowman.
Morning, everyone. My name is Sarah Bowman. I am a BCBA, and I also am a senior clinician with Behavior Change Institute, and I am joining today from Gainesville, Florida.
Great. Thank you, Sarah. We also have Sarah Brunswick.
Morning, everyone. I'm Sarah Brunswick. I'm up here in Wisconsin. I'm a BCBA and a clinician with Behavior Change Institute.
Great. Thank you, Sarah. And we have Shani here today.
Hello, everyone. I work for Chrysalis, and we provide services in Utah, Nevada.
Great. Thank you, Shani, for joining us. It's great to see you. And Trisha Joy.
Morning, everyone. My name is Trisha. I am an RT and a BCBA intern for Behavior Change Institute, and I am in Alamogordo, New Mexico.
Great. Thank you, Trisha. And Teague. T-E-A-G, Tammy. Thank you. Okay, Tammy. If you would like to introduce yourself via chat, please feel free to do so. All right. And then was there anybody that joined that I missed?
Hi, this is Jen Chavez from New Mexico Medicaid. Morning, all.
Good morning, Jen. Great to have you. Thank you for joining us. All right. So as I mentioned, for those of you that have not joined us for the last clinic, Brian Lopez is going to be conducting the second training in documentation of medically necessary treatment. Dr. Lopez is the executive director at Jumpstart Autism Center. He specializes in the diagnostic assessment and evidence-based treatments of children with autism spectrum disorders and other neurodevelopmental disabilities for the past 15 years. At Jumpstart, Dr. Lopez is a member of the diagnostic team. He works with the Jumpstart mental health providers to provide parent training and behavioral consultation, and he also collaborates with the ABA clinical supervisors to oversee the ABA programs. So, Dr. Lopez, we are very excited for the second part of your training today.
It's a little overwhelming to hear where this is being televised, or maybe not televised, but broadcast, and the number of people. So it really is a pleasure to be here and to participate, to share what where we've moved to here at Jumpstart around documenting medical necessity. And I'm extremely honored to have Molly, one of our BCBs, join us in kind of joining me in this process rather quickly to hopefully add a lot of flavor and perspective to how we've really changed our practice to effectively document medical necessity, which hopefully then down the line prevents a lot of challenges from insurance companies, and it also maximizes the services that we request for the clients that we serve. So ideally what I'd like to do today is initially just review what it was that we reviewed last week or 2 weeks ago as to why medical necessity is starting to become such a major issue. And then really get into greater detail around how to best document medical necessity and how we've kind of reviewed the different insurance agencies and what they're wanting in that documentation. And Molly's going to help or actually provide that flavor and description to what it is that we're doing as I review kind of the critical areas. So in a very specific case that we've been serving for the last 4 years, I think.
3, yeah.
Yeah, 3. So I hope that today will be very insightful, not only in terms of kind of the overall view, but then what one clinic in New Mexico is doing to try to meet the best practice and best serve the clients that we serve. So overall objectives, again, kind of review what makes ABA medically necessary, review some of the general challenges that BCBAs are going to face when documenting that medical necessity, and then go over very systematically critical components that are needed to be documented in those prior auth requests, and then add some flavor with the case study. And so ideally, this first part, I'm more than happy to take questions as we kind of go along. And Joy, I don't know how the group would do that. Is that something that you just jump in, or is that a question that's texted over or emailed over to you guys?
So we can have questions sent in either through chat if you would like to do so, and then we can go ahead and collect those questions. And then also if you would like to pause throughout the presentation, anybody that would like to speak up and ask a question via video can do so as well.
Okay, perfect. So I'll try to remember to pause in my thoughts, and so if not, just kind of wave at me, or you can bump me and say, hey, stop for a minute. It would be helpful. So
I can send the questions over to you through chat.
Oh,
If Molly wants to, if you want to keep the window open and Molly wants to keep an eye out for the questions.
okay, sure. Let's see. So,
I don't know if we can.
oh, I don't know. I don't know that I have a chat window open, Joy.
Okay, that's fine. We'll collect them and
Okay,
then we'll
that's fine.
ask them at the end.
That's perfect. So
Okay.
what I'd like to do is just, for folks that weren't able to attend last 2 weeks ago, is just review why this issue is so tough or so important currently. And to give a little bit of history, and that way we really move forward with an understanding of what it is that insurance is looking for. And so, again, just kind of as a review, understanding that our services are provided into either medical services or behavioral health services. The medical field really, before I guess recently, I've never really questioned why psychological services are medically necessary. Just as a clinical psychologist, just kind of went through and documented my reports, sent them in, and didn't ever think about it. And it really wasn't until some of the ABA stuff, providing more ABA services, sending in requests to insurance companies, those insurance companies saying, no, this is an educational service, or no, ABA is experimental, we aren't going to cover it. So then just starting that process initially around documenting why ABA meets the needs of the client and addresses those specific needs. And so over time, really understanding that, okay, we have to come at it from a very behavioral health, a very clinical perspective. And that's how insurance companies are really looking at everything that's the lens that they're looking through. And we have to understand that lens, because then we can best match what it is that we're doing, which we may or may not view as necessarily behavioral health or not, but that's where it falls. And so as we're able to have that understanding, we also know that it's been a little bit easier to get services approved because of insurance mandates. And those insurance mandates have kind of set the standard that, this is going to be covered. But now insurances are going to start saying, well, what's the quality being provided? How do we know that this individual is making progress? And that's the goal of the insurance company, is to ensure that the providers that they are credentialing to provide services to their members have the skills necessary to meet the need. And although that's the goal of the insurance, it really does create many barriers for the families of children with autism. It takes 6 to 8 months to get through the credentialing process. And then, it can take, we just had a kiddo go through, we did a couple of appeals, and it took about 3 months to get those appeals heard. And again, everything denied, but just to even try to get access to insurance. So it really depends on where those medical mandates or legal mandates are in your states. Even in states like Colorado, there's a lot of holes, and you aren't really sure what is covered, what isn't. And so there really is a big battle with insurances. So having all your documentation very well presented can help you with this process for sure. Last time I talked a little bit about the differences between educational and medical services. The problem that behavior analysts face many times is that many behavior analysts are trained in departments of education. And they're then asked to come into a medical setting and document or state that ABA is medically necessary without having much of the training around what it means to have a service as medically necessary. So that's just something that we have to be aware of and actually think about how we're going to address that, or how those individual providers are going to address that. Many times the insurance companies are viewing ABA just kind of from a historical perspective, view ABA as a habilitative service that is either habilitative, meaning the child never had the skills and it needs to be a service provided by education, or ABA is just experimental. And we actually just had a kiddo be denied ABA services because the insurance agency deemed the service educationally based. So this isn't something that, you know, is, I mean, yes, it's a historical perspective, but it still affects what you can get approved. And then also really to identify what, when you're going through and you're documenting, you're putting your thoughts in order as you document, really what you want to do is a service is medically necessary when it's in the best interest of the recipient. And that recipient has a diagnosed condition that results in debilitating symptoms, and really what we'll focus on is functional impairments. And then that those, that the rehabilitation, the services provided actually improve those skills, those functional impairments. Again, I talked a little bit just briefly about some of the insurance mandates, and you know, here in New Mexico, the New Mexico Autism Society has done a tremendous job in passing advocating and lobbying for very effective insurance mandates. The insurance mandates here are absolutely tremendous and allow us to really provide some comprehensive services to kids of all ages. The Medicaid and the work that Jen Chavez has done, Tina Goldsmith here, have done around Medicaid has been tremendous in really expanding what Medicaid would cover in for children with autism, not only up through the age of 5, but then through all ages. That many times years ago, or you know, in 2012, New Mexico was very far behind the times, even with a Medicaid mandate. And just recently with the changes that have been made, you know, I think that New Mexico in many ways is leading the country in ensuring that children have access to providers through their insurance. So those mandates have really made some huge changes, but it also then, insurances are now responding to how to, for lack of a better term, limit some of that. They no longer can limit based off of policies. So they're going to start limiting based off of the service isn't deemed medically necessary. So this really is a very timely discussion in terms of what processes each agency is going to have to get into place to really effectively document that the ABA services, the intensity and the actual service itself is medically necessary and warranted. And so one of the things that really immediately kind of presents itself, or one of the things that I should say Jumpstart had to resolve, is kind of the behavior analyst and what I'm calling is the conundrum. In terms of, you know, when Jumpstart started, it was, I really viewed it as a psychological company that provides psychological services. Well, most of the BCBAs here in New Mexico are educated through Department of Education, either at the University of New Mexico or online online universities, or they're trained in very experimental programs and don't have that clinical background to really understand exactly what it takes to really say something's medically necessary. So in some ways, we've had to adapt a little bit of thinking in how we understand what it is that we're doing and shift it away from kind of the educational stuff and really found it or base it in the medical and in the clinical. Here at Jumpstart, with me being a clinical psychologist, we've been able to create some systems around ensuring that medical diagnoses are accurately provided, but other agencies that don't have a clinical provider there on site are going to have to come up with ways to collaborate with primary care physicians to get an accurate and a comprehensive description of all the medical conditions that individual is facing. And then finally, we have to really look at a systematic way to provide additional training or receive supervision for the BCBAs around the medical component, the diagnostic component, and everything that it's going to require to effectively document the disability that's there. Many of the things that we'll review today is stuff that many departments of education don't even touch on. For example, standardized assessments. And how do you report standardized assessments if you've never been trained in it? And so seeking out either additional training in that or consultation discussion there around. And so then really the other piece in kind of the conundrum is really behavior analysts understanding that the medical field, the behavioral health field, really cluster symptoms together. And it's that clustering of behavioral symptoms that we then get a diagnostic group. And it's those diagnostic groups, those diagnostic categories that insurance companies are using as kind of the gatekeeper. And so as opposed to looking at very discrete, measurable behaviors, we're many times thinking about kind of omnibus or kind of overall functioning and overall behaviors, a cluster of behaviors. And we have to really embrace the idea that we're really dealing in many ways. And DSM-5 is a little bit different because it's very much more evidence-based and research-based. But in many ways, we're dealing with many hypothetical constructs. And we have to use that to our advantage when making these requests. And we just have to embrace that fact. And, you know, when we're making the request, now our treatment goals can be different, very specific and very behavioral-based. But we just have to know the lens that the insurance companies are looking through is one of general constructs. And they don't know that they're looking through that lens. So we just have to understand that as behavior analysts. Let's see. So then really getting at what is the documentation for medical necessity. As I kind of mentioned earlier, or at least 2 weeks ago, that previously just saying a child had autism, actually, you know, more recently, a child has autism, therefore they qualify for autism services or ABA, was okay. Now with the reaction of many insurances, that's no longer acceptable. Okay, well, yep, they do qualify, but what is it about this service that makes it medically necessary for that child that has autism? And so we're really going to not only have to document that the child has autism, but the level of severity of that autism and any other conditions related to autism, many times called secondary symptoms or any other medical symptoms. There has to be clear evidence that those symptoms are resulting in substantial impairment in daily functioning. And so then how are we going to measure that? Because many times insurance companies, and they will be lost if you send in an ABLS or a VB-MAP. A criterion referenced assessment like that, they aren't going to understand, and it's just going to make your attempt to refute or appeal any denials very difficult. Again, insurance companies talk in terms of overall functioning, they talk in terms of overall diagnoses, and they want to see where this individual is compared to other individuals. They don't necessarily want to see ipsative comparisons, meaning where this individual is compared to themselves. What are their own strengths and weaknesses? No, they want to know precisely where is this individual compared to other kids that are 3 years old. And that this individual's functioning is much lower than those the typical 3 years of age. And then really, let's see, I kind of got the screen in my way and it's hard to see all that. So the documentation of ongoing treatment is supporting that, supporting the fact that the therapy is having the effects that are desired, and it's actually having such a positive effect. The growth is beyond what would be expected just for that child's individual maturation. And then finally, the treatment needs to address the core symptoms and, as I mentioned before, any other potential medical conditions. So, hold on a second, I'm trying to advance. There we go. 1 second. Okay. So then what is it that we have to document? And so this is the stuff where Jumpstart really has taken the last 6 months to make some pretty substantial changes to our practice and to our template, really starting at a general review of a variety of major health insurance providers and reviewing what New Mexico Medicaid requires. and coming up with a general template that really addresses all of what the insurance companies are requiring. And so really we have to be able to document the data from which ABA treatment is supporting that those functional gains are being made. And we'll show you a graph here in a second that really goes, that we will include in our reports that shows that the ABA treatment is having the desired effect over and above what we would expect for that child, just given general maturation or general growth, given the child getting older. And it really is, you have to put a statement into that report that X number of hours of ABA treatment are deemed medically necessary. And I've seen that without that statement in there, some insurances will kind of say, oh, well, since it isn't deemed medically necessary, we'll approve this many hours. We'll approve a quarter of that. Okay, and then you're kind of stuck. But if you have it in your report as just a general template, that will make your life just so much easier. If you ever have to go to the point of an appeal or, a review or anything like that. And then finally, you have to be able to document that the medical condition is actively resulting in functional impairment. For us, what we've done, and this can be done either with, ideally it's going to have to be done with the standardized assessment of some sort. For us, we use the SIBAR, the Scales of Independent Behavior Revised, but for that, and that's the reason we use that one is because it's a questionnaire around adaptive functioning that has a severity scale at the end, but it also has a measure of challenging behaviors, and the parents can do it as a self-report. It isn't an interview that requires a lot of my time or the BCBA's time to sit down and do the interview. Part of this, though, is you have to inform the parents of how to score this, that in these standardized assessments, we are not looking for what you think your child can do. They have to demonstrate it. Because if so, and we just actually had this come up where a parent completed a SIBAR and based off of her reports, the child's skills are above age level. All right, we now no longer have documentation of functional impairment. And that's going to potentially affect that child's services. But that standardized assessment then gives you a standard score in which you can have standard deviations, and you can show how much lower this child's functioning is in whatever domain compared to other individuals their same age. And we'll review that here in a second. And again, the idea of criterion reference, it isn't that it's inadequate, the SIBAR, the VB-MAP, the BLAF, the ABLES, any of those. Not that they're inadequate, that they're very effective for treatment and documenting treatment gains, but for standardized assessment and showing that where this individual is compared to others, it really isn't that good. And the insurance companies, you just have to assume the person on the other line doesn't know what autism is and doesn't know what the VB-MAP is, doesn't know, looks at treatment goals and has very limited understanding. So you just have to make a very compelling argument of stuff that they might know. Oh, there we go. So this is a graph of one of the little guys the little guy that Molly's going to talk about here in a second. And this is just a way that we can show that the data documents functional growth. Overall targets over time. This is a kiddo that we had to document. Here in New Mexico, Medicaid insurance was stopping ABA service at the age of 5, but then the Medicaid changed in I think January of 2015. It took a while for that to take effect. It really took effect May of 2015, if I recall correctly. Yep. And this child's birthday was June or July? July of 2015. So we immediately increased his comprehensive services, meaning he went from 15 hours a week, which is the data to the left of the red line, to 40 hours a week, which is the data to the right of the left, or to the right of the line. And we were able to use this graph as a means to say, you know what, we've been able to change this child's developmental trajectory. We are requesting comprehensive services continue beyond the age of 5. And so this is a very, I mean, someone looks at this, it's a very compelling argument for you. And having data like this and documenting that data just makes your life so much easier.
There you go.
You want to talk about this one a little bit?
Sure. So this is the same client that we had talked about, who is now just over 5 years of age. And what we really wanted to point out in this graph is, you know, from the previous graph we saw, it stopped about here. So we saw right after we almost doubled his access to treatment, his hours, we saw this spike, and we saw a real change in the rate of his learning. What's really cool is if you look right here, this is a reassessment. So we're now really seeing that we've taught some pivotal behaviors, and so he's now learning from his environment. So these are skills that we haven't taught. So we taught identical matching, and then when we assessed non-identical matching, he had all these skills that he started to learn and generalize, and now is maintaining. And so that's really what you know, we'd like to talk about this graph.
And this is the same graph will go into his upcoming renewal request to show that, you know, again, we continue to make progress beyond what would be expected given his, you know, developmental maturation. Again, his developmental we don't have, the problem is how do you measure developmental maturation for an individual with severe disabilities? And what we would say is, if you look at the data to the left of the line, that's what his maturation is given about 15 hours of service. We would predict or suggest that his learning rate is going to be substantially lower if he didn't even have 15 hours. So we know that I mean, he has it takes a lot of teaching to teach Johnny how to do skills. And reducing services are going to really have him plateau. And so we can make that argument fairly eloquently, I think, with some of this data, as well as other data that we'll talk about here in a second. So let me check one thing real quick. I don't know, we should have had their slide about what Johnny is, where Johnny is.
Did you pass it? Go up.
I don't think I did I?
I think you did.
Oh, I'm sorry. I was like, wait, we should have already talked about Johnny. Where's Johnny? So I'm sorry.
It's okay. So, give me 1 second. There we go. Okay. So the case presentation for today is a 5-year-old male. He's about 5.5 now. He was diagnosed at the age of 2 by a multidisciplinary team. His current diagnosis is level 3 severity autistic disorder, and we'll get into the severity level based on the DSM-5 in a little bit. He received about 15 hours of ABA services for the previous 2 years, and then starting in May, he's been at about 30 to 40 hours of ABA services. He is currently not in any other educational setting or therapy setting, so he does not receive any other services. When he started with his initial treatment focused on man training, reducing his motor stereotypy, and teaching imitation skills. So when he first started with us, he didn't have any play skills, he didn't have any communication, he had very restrictive interests, and most of his session focused really on reducing the motor stereotypy so that we could teach new skills. It took him about 6 months to learn one imitation skill when we first started with him. To this day, his scores are predominantly in the level 1 of the BB-MAP, so his functioning level is about 18 years of age. He communicates through PECS. When he first started, we tried sign with him, and that really wasn't his communication. He's really a visual learner, and so we tried PECS with him, and he's pretty proficient in that now. He's still nonverbal, but he has some emerging vocal imitation skills, mostly vowel sounds. And he has ongoing severe impairments in receptive language, so he only follows a couple of simple instructions. He cannot receptively identify items. And his current strengths are motor imitation, both fine motor and gross motor, and visual performance skills. We started working on toileting a couple months ago, and he's done pretty well with it, but he's not yet PAL trained. And we'll get into kind of the medical piece that goes into why toileting is taking so long as well.
Okay. And I was actually going to, is it okay if I interrupt with a question from our audience?
Of course.
So one of the questions that actually came in a little bit ago was related to toilet training, and somebody is asking, so you might get into this in a minute, would not being toilet trained by the age of 4 be considered a secondary medical symptom? So I thought that I would go ahead and bring that up since I saw that on the slide. And then the other question I wanted to ask is, because you have a multidisciplinary team at Jumpstart, would you also be able to describe the team that is working and consulting on this case as well?
Sure.
Go ahead.
No, you go ahead.
So really, so it's myself as a clinical psychologist working and really consulting to Molly as the overseeing clinical supervisor. Molly really directs everything related to this client's services. We have and so from there, I'm going to let you take over.
We also have a BCBA SLP, speech language pathologist, on staff, and so I also consult with her. We started feeding with Johnny about around the same time we started toileting. We really wanted to focus on adaptive skills, self-care skills, really, because we found that those would really change his quality of life, and that he was showing some signs of readiness. And so when the talk about feeding and the needs around feeding came up, we did seek outside consultation, but within Jumpstart, we really do rely on our SLP for consultation around those areas as well.
And then I think the other piece of this is as specialty areas come up, this individual has some serious GI issues that we then just work with the GI docs, or make the referrals, try to get the GI docs to take over from there. And that's actually an interesting piece that we'll talk about here in a little bit, that kind of regardless of whatever team you have assembled, thinking about how you're addressing the medical piece is an important part that can be eye-opening at times, and I'll get to that. And we'll definitely get to the secondary symptoms here because that is a critical piece. And so as I was going through this presentation, you're supposed to bump me at some point and say, stop, cut. No, and I was kind of like, wait, we should have already, before we got to the data, we should have talked about Johnny. So the one thing that I hope is that you can see that Johnny's pretty impaired, has some very significant needs. Now we have to be able to effectively communicate what Johnny's needs are. And I mean, we're talking to a group that really understands what, the lingo that we're saying, the different skills that we're talking about, but the insurance company doesn't. So as we run through our report, hopefully you guys will be able to see the depth that we're going into and the means that what we're documenting then gives a good picture for where Johnny's difficulties are. Okay, so that's what we're hoping for. And from this point on, don't hesitate to interrupt, because a lot of it can be a little nuancy. Don't hesitate to interrupt whatsoever, okay? So, see, I need to let you do this because I keep on pressing one, and that's, I think, why I skipped one. Right. So we talked about this a little bit, right? Talked about the ABA data. We presented some ABA data a second ago. Talked about functional impairment, standardized assessments.
Were there questions?
Yeah, were there questions about that? Particularly around the standardized assessment stuff.
No? Okay.
Data is good. Data supports your arguments. So really now we have to document how our treatment plan is addressing the behavioral symptoms or medical symptoms of ASD. We'll get to that piece a little bit later. So let me kind of jump to really the critical piece about how we're going to document the severity of autism, or how Jumpstart has elected to or decided to document severity of autism. And what we have found, or what I found as I was reviewing what insurance companies are going to mandate be part of the report, to say that autisms or the ABA is medically necessary. So in my review of, I think I went through 10 different insurance policies to figure this out. This was basically what I came up with as kind of a general outline. So we have to document the core symptoms of core deficits of autism. We have to have goals addressing that, let me say. Or we have to have goals addressing secondary treatments of ASD. So here I think of those as the general, this is what our skills acquisition piece is going to focus on, are the deficits, the core deficits or secondary symptoms. We're going to teach skills around those. But in addition to teaching skills, every insurance company is going to want one or all of these documented and treatment addressing. So it's the core symptoms and a plan to reduce any challenging behaviors and or any medical complications associated with autism, that your treatment plan has to address that, and or any safety concerns. Now, let me talk just briefly about safety concerns. Again, you have to know that we're coming from this, or insurance companies are looking at this through a medical model, a psychiatric model, or a psychological model. In psychiatry, in the medical field, a safety concern, one's concern about safety is that they're a danger to themselves, to others, or gravely disabled. And that's where we have to be able to kind of document that level of threshold. Now, are we saying that they're going to commit suicide? No, that's not what we're, that's many times where where the medical model goes now is to prevent for danger of self is suicide. No, that's not necessarily the case. But with severe SIB, that can become a danger to oneself. And we have to document that, and that's where we would put this stuff, okay?
Well, and through safety concerns, you can even consider things like not responding to name or not following instructions. If Johnny runs out in the street and mom calls, Johnny, and he doesn't respond, that's a safety concern. That is a danger to himself. So it doesn't necessarily have to be extreme SID. It could be, severe impairments in receptive language.
And that's where we get to put our skills to work to really tweak what it is that what we're doing in treatment to meet that medical component. And we'll talk in great detail about that here in a second. So again, just as a general review, core symptoms of autism are the triad of symptoms: social impairments, communication impairments, restrictive repetitive behavior. You can throw the sensory stuff in there also. Typically, ABA is not going to just solely address that sensory piece. You're going to have to address the social communication, is really where everybody's going now. And then just to know that, not many people have, that aren't in the medical field don't think of secondary symptoms, more or less positive or negative symptoms associated with autism. But the secondary symptoms, ways to kind of think about that. A lot of times we talk about defective scanning in individuals with autism. Well, defective scanning really is a secondary symptom of autism. We can talk about attending. We can talk about overall activity level or impulse control. Those are very specific, again, not behaviors, but everybody else other than behavior analysts will think of those as specific behaviors. Just know that. So, the other piece is thinking about other psychological conditions or psychiatric conditions that we can then document and put into our treatment goal, as the treatment really is broader than just ASD. So things like anxiety, depression, obsessive compulsive disorder, ODD is oppositional defiant disorder, and many times our kids aren't going to meet the full criteria of these, but we can give an unspecified diagnosis that then, again, I hate to say that it pathologizes the behavior, but understand medicine is about pathology. If it isn't wrong, we aren't going to fix it. We don't need to give it attention. So we have to pathologize the behavior to make it a clinical focus to then justify treatment. And then also any other medical condition. And these are some of the conditions that the question was specifically addressing. Things like eating disorders, pica, enuresis incapricis. These are sleep disturbances. Obesity, where we get kids kind of on the fringe, due to severe eating disorder or food intake problems, or feeding habits. You get obesity and diabetes, high blood pressure that we have to address.
So I'm not a clinical psychologist. What's encopresis?
Oh, enuresis and encopresis. Enuresis is accidental peeing beyond what would be expected for, not toilet trained, for bladder, beyond what would be expected for developmental age. Typically, we'd expect developmentally around age 3, you'd get toileting. Somewhere around there, and it's maybe 6 months. Same thing for encopresis, that's bowel training. So they have bowel accidents. Again, we have to, if we diagnose it, then it just gives more description to the nature of the child's difficulties. And yes, we're pathologizing a developmental delay, but it talks to the child's functional impairment of the disorder, right? And it gives more, it gives more cannon fodder for the reason, the medical approval or the medical necessity of ABA, and particularly around the intensity that you're requesting. Are there other questions about secondary symptoms? So one of these two have to be addressed. Okay? Oh, okay, yeah. So Molly's going to share the report, or part of our report. Are you guys able to see that?
Well, not yet.
Oh, not yet.
1 second.
We're navigating.
And just a reminder that if you wanted to chat in a question, please feel free to do so, and then we will go ahead and ask the question.
I think if you just put it on the screen, then we can just flip back and forth now.
Okay, so one of the questions that's coming through, and you might be discussing this a little bit more still, is related to the toilet training as well, and is specifically related to insurance companies that are denying toilet training by behavior analysts. And so really trying to get a better understanding of how we can document that, those secondary medical symptoms in order to receive approval for treatment.
That's a good question, and I think it really comes down to not knowing anything about the case and the age. Really, are you ensuring that the diagnosis of encopresis is clearly there? You could probably get a letter from, and this is one of the things that we've done with our pediatricians, is basically come up with a form letter that we send all of our pediatricians to then put on their letterhead documenting ABA is medically necessary for and we give them exactly what we want them to say, right? And then they put on their letterhead and send it over to us, and we include that when necessary. So that's one thing that you can do. I think the other thing is really demonstrating how the bowel functioning is, one, abnormal for developmental age, and 2, is causing functional impairment. Right? So how is that then, and causing functional impairment across multiple settings? Not only for the family, is it limiting access to other interactions, and what skills do you have to teach accordingly? Because again, here we would say, the diagnosis you're treating is encopresis, but then what else? Are there challenges? Is he starting to smear? Is he throwing? Is he, what else is happening around what challenging behaviors might be happening around the toilet training that's our obstacles. And so I think you just have to really ensure that you're actively documenting all the components that are going into the disability, or all of the components that are going into the functional impairment, and really give that insurance company a good flavor for why this is clinic or medically necessary. And without knowing more, it's hard to say. But ultimately, it's going to have to be more than just encopresis, chances are. Because chances are, encopresis should be able to be addressed in a less restrictive or a less intensive environment, right? Why can't that just be done through parent training? That's probably what they're also arguing. So you have to give the data and the argument that it's going to require a very intensive program to meet those needs, and the needs are just significant. All right, so let us kind of go into a little bit of this, and this may give you a little bit better flavor of how we've chosen to give the insurance companies a better flavor for the severity of Johnny's needs. Go ahead.
So to start out with, we scheduled a time to meet with Mom and to talk about more in depth Johnny's needs and his impairments and diagnoses. And so over the years, through parent meetings and seeking outside support and collaboration with specialists, we had a good idea that he had feeding needs, he had sleep disturbance, he had severe GI issues and was on Miralax, and she would report what the specialist would say, that they did an x-ray and he wasn't impacted, that the feeding clinic had these suggestions, the PCV said this. And so we had somewhat of an idea, but really sitting down with her, we realized the need and that he actually had a PCV intern that changed every 6 months, so he really wasn't getting follow-up care. So these things had been addressed, but nothing had ever been or had been reported and suggested had been given, but there was never any follow-up. So after he had an x-ray and he wasn't impacted, there was no follow-up on what to do next based on his needs. And so Dr. Lopez and I, or Brian and I, sat down with Mom, and we really got into the nitty-gritty of all of his diagnoses and all of the specialists she had seen or had not seen, and started, we referred her to a better PCP, and through the PCV, she's now seeing a GI, Johnny is now seeing a GI specialist, I guess not weekly, but, somebody who's really following up and taking care. And so, do you want to go on?
Yep. No, so part of this was really realizing that we had to give the insurances a better understanding for all of our kids' comprehensive needs and how autism affects multiple systems. So what Molly's talking about is basically we've changed our practice here at Jumpstart to where we do a psychiatric interview, basically. So myself, the clinical psychologist, will go through and do a comprehensive review, coming up with not only reviewing what medical diagnoses are there and putting those in this report, which you can clearly see. This individual, Johnny, has been to the SAFE clinic here, which is a specialized feeding clinic, and we had specific diagnoses from them, but then also what other diagnoses are present that are of clinical importance that need to be addressed other than just autism. So now what you see is in our report that, okay, it's not just autism. It's much more than autism. And these are the things that are going to require clinical attention. And yes, so this would be an example of some parents would be, Johnny's 5. All right, yeah, Johnny isn't toilet trained. That's what they're coming to you as the primary concern. Well, a child that isn't toilet trained at 5, there's actually a lot more going on. And really effectively documenting everything that's going on will help you, combat the denials. So what a psychiatric interview is, and this is where that collaboration is going to have to come in hand. Jumpstart has it built in with me. Other agencies have it built in with other mental health providers. But a psychiatric interview is basically a billable hour where you can sit down and go over the diagnostic criteria and come up with all of the areas that need to be treated. You can work with a treating psychiatrist, you can work with a treating developmental pediatrician or a developmental pediatrician, or the treating generalist pediatrician, and to get these done. And it's just basically many times asking the nurse to go through the chart and document what Johnny has been diagnosed with. We have a review questionnaire where we ask parents, what has Johnny been diagnosed with and when was he diagnosed with that? From there, I'll do the psychiatric interview with the clinical supervisor, and that way, because there's so much rich information that comes out of that psychiatric interview, and it really can change how we're addressing treatment, right? So making recommendations that this family shift primary care provider. And we shifted that we directed that family over to one of 2 providers. The first one wasn't taking a patient. The second one I think I don't know, did I call the pediatrician? I didn't. I just thought that we could get him in, and we luckily got him in, and that group has a GI doc and is truly making a difference. In fact, the mom called you right after.
Yeah, she actually called me right as she was leaving the appointment in tears because she was just so grateful that all of these, secondary needs were going to start being addressed on a medical level as well as a behavioral level. And so, and these were things that we thought were being addressed in the past because she had reported, yes, I went and saw the specialist, or yes, my PCB told me this, but they weren't really being addressed. They had been talked about, but nothing had really come to fruition.
Yeah. And so I know that this sounds like a lot to do, and it really is. But the thing that the behavior analysts have to realize is that the amount of service we're requesting many times is so much above and beyond what is typical that many insurance companies are trying to have over the past few years tried to figure out how to even reimburse for this, because many times, in insurance world, you get one unit once a day at the most. Many times you only get one unit of service once a week. And, now we're asking for 8 units, potentially 12 units in a day. And they had to go in and figure that out. So that we really, what we're asking for is truly many ways above and beyond what most medical service providers deliver and what insurance is typically used to. So we just it takes a lot to document this, but it really is worth it.
And another piece is documenting that these services are not being provided elsewhere. So they're not being provided in the IEP. They're not being provided through 30 minutes of speech a week. They're not being provided at OT. And that's something else that we found out through, the paperwork that we've been sending home about medical diagnoses is also what other services are they being, is that child being provided, and what are they treating? So we can make sure that we can say in our reports that no, they're not getting services or help with this elsewhere.
And so then this other part that Molly's going to talk about is the SIBAR and how we report the standard scores around measuring functional impairment for Johnny. So,
the SIBAR Brian talked about it a little briefly, it's a standardized assessment. So the interview or the rating scale that we send home that parents complete is based on a typically developing individual up to the age of 72 years, right?
Mm-hmm. Yep.
So they take Johnny, who's 5, say it was completed when Johnny was 5.5. They take that assessment and they compare it to others who are 5.5. So a big pool of individuals. And where does Johnny fall based on other 5.5-year-olds? And so we can see that he's in less than 1 percentile. And his standard scores for some of these don't even come up because he's so limited in his skills. Yep. And so this chart can really represent visually based on his peers where he is, his broad independence, so his overall independence, as well as very specific areas.
So go ahead and switch back to the presentation. And so for those that don't know what a standard score is, a standard score is, you basically, for the SIBAR, it's a mean of 100 with a standard deviation of 15, right? And so then that's where we get kind of that magic number of 70. That magic number of 70 is 2 standard deviations below the mean, which then is in the significantly impaired range of functioning. So that 70 is significantly impaired. Johnny's at a standard score of a 19. That's almost 4 standard deviations below the mean, right? And this is something that insurance companies are going to look at, and they'll know standard scores. Most people reviewing will understand standard scores. If not, and it gets bumped to a review, that review is going to be done typically by a clinical psychologist for ABA stuff. That clinical psychologist is going to immediately know what a standard score is, see that, and know precisely how impaired the student is or the client is.
Another thing with the SIBAR that we found out for Johnny is that a lot of the skills mom reported he cannot do were things that he can do in this setting. So it also showed us that he's not generalizing, and that we need to put a heavier focus on making sure that the skills that we're teaching here, we're really focusing as well in home sessions.
And so then one thing that we've tried to do in terms of documenting severity, and the idea of documenting autism symptom severity, there's no great way to do it, unfortunately. And so one of the best ways currently is the DSM-5, and I don't know if many of you guys really knew this, is that it really changed how we're going to go about diagnosing. There's no longer the 3 axes of diagnosis, and they're really trying to, they move to the idea that you want to try to describe the individual the best that they can, and that's what the diagnosis should do. So if you recall, when you saw our report, that it was written out in general kind of paragraph form, and someone could read it and say, oh, wow, that's a lot. I really get a better description of what's going on. And so what the DSM-5 did is they actually gave some symptom severity levels. And I don't need to review this right now. You can go to the DSM-5 and actually see this. These are just general descriptors. And again, it's kind of just a, all right, it's right about there. But it then gives the insurance company a level, meaning requiring substantial support for a level 2. And then a level 3, which Johnny is, requiring very substantial support. And it gives kind of general descriptions of what those impairments, what the behaviors would look like for that. And it's just another way to document how severe the autism symptoms are.
Are there questions?
Yep.
Yeah, I think we've had several questions come through, and I think that they're going to be, there's going to be a good bit of discussion around them. Did you want to, do you have just a couple slides left? Do you want to finish those, or do you want to go into?
No, we have quite a, I don't know how many slides we have. Let's see, hold on.
Okay.
We have about 5 more slides.
Okay. Well, maybe we could go through some of the questions. Monica, I see that you had a couple that were coming through and some comments on there. Do you mind sharing your question?
Yeah, no problem. I would love it if we could discuss those services that are actually duplicated by other services. I do have a client, for instance, that's learning to communicate with PECS, and this is a parallel goal that we have with the school. So it's in his IEP. It's also targeted in speech therapy, and then we also work on it at home. And it's even a parent goal. And so we are working on this together, and we even have team meetings once in a while. And so how do we address these specific goals that are duplicated and necessary?
Yep. That's a good question. I think it comes down to what is it that makes it necessary, right? So most educators and most speech therapists working in the field of education aren't going to understand verbal behavior analysis, and they will not be able to comprehend how, they'll come at it from a very speech-driven paradigm. And I think it's really, you can have similar goals, right? But what is it, kind of task analyze what it is that you're trying to do specifically with your communication goal, and how the methodology is different to bring about that change. And so you can have a similar goal, but the approach, chances are different. And that you have data documenting, one, that this level of intensity is needed despite the overlap. The parent teacher, or the parent piece, has to be there for the communication. So that just further bolsters your argument, and that no one's teaching the parents around and I don't know if you're doing verbal behavior or not, but around that piece, right? So you can make that argument very effectively around the specialty of service, and you might have to change it slightly because the education department's going to say, oh, well, this is affecting his ability to access the curriculum, whatever curricula they're teaching. Right? We would say that this communication disorder is a functional impairment, that we're going to address the functional impairment by teaching the parents how to generalize the skills we're teaching, as well as teaching the manding, teaching the tact-demand transfer, all of that stuff. right? And you can give a better description for that. You want to add?
No, you said what I was going to say about the parent piece is that the parent goal can be written in a way that it's changing parent behavior to then support your secondary or your other goal of communication. So
yeah,
that's just going to add.
Yeah, no, that's a great question though.
Thank you.
Thank you.
And Zoe, I think that you have something to contribute too, right?
I do. I guess my first question is just in terms of format. Do you want me to save questions for a specific time, or do you want to kind of just put them out there now?
I say put them out there now.
Okay. Hi, Brian.
How's it going, Zoe? Good to see you.
So I have a couple of questions, and they follow up on the last question. So although I'm a licensed clinical social worker, I run into some of the same challenges in terms of documenting medical necessity. So the issues that I run into around school are, and the arguments that I've used that have sometimes been more successful than others, is one having to do with the criteria that really the medical necessity and the educational services, right, have different criteria. So for education, it has to be that they have one of the exceptionalities that qualifies them for special education. And then that has to be a barrier for them to be able to access the educational environment. And then services fall from there, right? As where medical necessity really has to do with functioning in the community and the home, right? And that they are really mutually exclusive in the sense that they meet separate needs, separate criteria. So you may have occupational therapy in the school that is allowing that child to access their educational environment, but that occupational therapy that they're going to get in the community is addressing different needs. It's addressing sort of the needs that they have, the medical needs that they have in the home and community. Does that make sense in terms of being able to differentiate that? Do you have any?
Yeah, I think that's a great point, Zoe. And the only other thing I would add is, according to and I reviewed this a little bit 2 weeks ago, that according to the definitions of medical necessity through Medicaid and Medicare, is that it really, the service, the medical service has to be of medical standard.
Okay.
Right? Educationally, there's no standard there. It just has to help them.
It has to exist.
Access, right? And so that's where you can kind of get some of the unusual interventions, the very idiosyncratic interventions to the therapist in education, and it's all right. But for the medical field, it has to be of a medical standard. That's why we really talk about evidence-based practice.
And then I wondered too, in terms of a lot of the families, I think that many New Mexicans work with in the insurance world, they're working with TRICARE. And so I wondered if there were some differences between documenting medical necessity for TRICARE for sort of the military world versus the civilian world. And that's it. Thanks, Brian. I appreciate it.
No, that's a great question also. It's good to see you, Zoe. TRICARE has a very specific approach to how they want their reports written, and if you don't put in their verbiage, and they aren't going to tell you what that verbiage is, you kind of have to find a reviewer that's willing to give you the exact verbiage, then it's good. But they have their packets, 12 pages or something like that, and you have to address every single piece in that 12-page packet to document it. Right? So the stuff that we're reviewing here is in that same guise, in that same information. But it's very specific. And I think basically if you haven't done TRICARE, the easiest thing to do is get their packet, generate a report that follows their approach, and put it all in there.
And what Brian had said earlier, when we came up with a format that works for us, we really took into consideration what Medicaid was asking for, what TRICARE was asking for, what New Mexico was asking for, what Colorado was asking for. So that way we really did address. So there may be things in there that are very specific to one insurance, but we're putting them in all of our reports because we have found that they more than support medical necessity.
Hi, Brian. It's Kathleen in Oakland, and I have a question for you as well. So one of the comments that came through the chat box was that diagnostics is, of course, outside the scope of practice for a behavior analyst, which I know you touched on. Jumpstart is fortunate enough to have you as a licensed clinical psychologist in-house, and so for organizations that aren't so fortunate, can you talk to us a little bit about how you would recommend we coordinate care with those outside providers? Specifically, I loved when you were talking about toilet training and trying to get a diagnosis for enuresis and capresis. How do we start that process as a provider, and how do we include the family in that process?
And you know what? I think that's a great question that I don't know if I know the entire answer. For us, it's easy, right? Yeah. I mean, and for any other agency that has a built-in mental health provider, it's an easy answer, relatively. But even those, Jumpstart, I had to make specific times to my time allotment to do a psychiatric interview with every single one of our clients. Well, that takes the agency to support those changes to be made. So I think that, kind of part of this is it's going to be an agency decision on how to best accomplish the goal. Mm-hmm. So if you don't have someone in-house, then it's what is the agency going to do? What systems are going to be put in place so that they engage the primary care physician? Mm-hmm. And how are they going to make it easy for the primary care physician to give you those diagnoses to accurately diagnose, right?
For the referrals.
For the referrals, right? And that's the easiest place to start because they're the most accessible. They're the gatekeepers. Additionally, many agencies may elect to develop a pretty close relationship with a mental health provider. And, for example, up in Denver, I'm not up in Denver, and really working with a couple of my close friends to do this piece for us. And, okay, is it billed through their practice or through our practice? And are they independent contractors or do they bill for it? And, it's working out those pieces to ensure it gets done. I think the same thing. And then ultimately, it's developing a relationship not only with a mental health provider, just kind of in general, but I think it's also someone that is fairly familiar with autism. Okay, so that there's less of those, because many of these diagnoses down here, most psychologists would not give to a child with autism, like oppositional defiant disorder. Does this child have the classical oppositional defiant disorder? Not necessarily, but could he meet the criteria? Does he meet the criteria? Yeah, he does. But the goal of that diagnosis allows us to target specific treatment goals that otherwise wouldn't really be tied. And this is one thing that we do that we're hoping to show here in a second, is that every goal that we have is not only tied to the diagnosis of the or the core symptom or secondary symptom, but then any other medical diagnosis. That way the insurance companies see that this goal is not only addressing autism, it's addressing other stuff. So that's one of the reasons we go through this extensive, the extensive labor of documenting that. And ultimately, it's a lot of legwork. And so how does an agency problem solve that legwork to remove the burden off of the BCBAs? Mm-hmm. That way they just have a document that has it all and they just put it in a report. That's going to be pretty specific to each community, to each agency, and those resources that they then have. But it all comes down to collaboration.
Yeah, that's excellent.
Does that answer your question?
Absolutely. Thank you so much.
Okay. So one thing that I want to do is I do want to get at, because we were talking about symptom severity. And this is a really important thing, that if you ever go to review, you have to be able to document symptom severity. And so this is something that we put a lot of time and effort into documenting for ourselves, and to be able to show symptom severity. So do you want to talk a little bit about this related to Johnny?
Yeah, so we've come up with, based on the DSM-5 and their verbiage on severity, we've come up with a table that visually represents how we document and almost decide whether their services should be provided and whether they should be focused or comprehensive. And so you see here for Johnny, a lot of his severe his impairments fall under severe impairments. And so it's a rating scale, and these numbers are based on a template that we have put together that says what a 0 is, what a 1 is, what a 2 is, what a 3 is.
It objectively defines them.
Objectively defines
And we include that template, that table, in the report. That way any reviewer could look at it and understand immediately what it is that we're related to. Do you mind if I scroll down?
Yeah, it's at the very
Yeah.
bottom.
And the only other thing I want to say is these are things that many times you're going to be asked about in a review about severity, these skills right here. And that's why we came up with these specific ones, was because in the reviews we were getting asked for, these were the ones that typically came up. So from that scale, right there, you can see how we basically just came up with a 0, a 1, a 2, 3, and a 4. And there's some arbitrary, or 5. And there's some idiosyncratic to how we wanted to define them, let's say. So everybody can kind of come up with their own. Just that way, it's clear how you're categorizing this.
How you're putting a subjective number on objective behavior.
Exactly.
Well,
exactly.
and it's good because it's a visual representation. So it's hard, if you've never seen a BB map before, it's really hard to figure out what those acronyms mean and the numbers down the side and what a barrier and a transition is. But this really shows, okay, if I look at maladaptive behaviors, I can see that, he's pretty severe in the challenging behaviors that he emits.
And Joy, I know we're a little short on time. How much more time do we have?
No, we are fine on time. Clinic goes till 11, and so you can take up as much or a little time as you want. And I know that we have plenty of questions coming through as well. So
okay. So I think the rest is actually pretty straightforward. But I think this idea of the severity scale is an important one to capture. So are there questions about this?
yes, some questions are coming through about the severity scale, and they are, so this is something that you developed within your agency, Jumpstart, specifically? Okay. Yes. And the question is, who is completing the severity chart?
The BCBAs.
So the BCBAs are filling it out, and it was developed at Jumpstart, so it not a standardized form.
Nope.
Did anybody else have any questions about it?
Yeah, I wish it were standardized, but
yeah.
I mean, basically, it's just to give the insurance company a visual as well as a specifically defined definition for each one of those numbers is all we're basically doing. So everybody could basically do this.
Okay. And now people are requesting if they can get a copy. Is that something that you would be willing to share?
I don't know. Let me think about it.
Yeah, they'll think about that. Okay. And since you have started including these within your evaluations, have you found that you've had fewer treatments that you've had to submit for medical review or appeal?
Since we've had 2 go to appeal. One was through an insurance company that is basically Satan, and it doesn't matter what you document, it's going to be denied. The second one was in January. The kiddo switched insurance companies. One insurance company approved a comprehensive service. I think it was 30, 35 hours a week. The new insurance company said, no, we'll approve 10 hours a week. And so we appealed, and we got an extension of all of like 3 weeks before they mandated that we reduce it because of the child's age. The family then decided, oh, we'll buy another policy, and they switched policies and are back at comprehensive. But we were able, with the documentation, to effectively argue an extension, at least for a transition period, to allow us to target, skills accordingly. Very little pushback, but they did limit it. So, I think the thing of it is that what this has really allowed us is some of those reviews can be kind of stressful, especially if you haven't ever been through it. But these forms, you have all the data. It's all right there, and it's just easy to review. And you can say, oh, well, as I documented here, this addresses that question. And it just makes it a little bit easier. For example, if we start talking about challenging behaviors, and that's one of the things that you put in there, most insurance companies are going to want, okay, not only is there a challenging behavior, but what's your plan to address that? So you have to include it. Do you want to talk about kind of our prior auths, or as we start serving a kiddo, how we generate our FBAs for our first request?
Yeah, so within all of our reports, we do now include a functional behavior assessment and a behavioral intervention plan. And so when a client first starts out with us, we only have, 10 to 20 hours of assessment time, if that. That's very generous. And so during that time, we collect as much data as we can on ABCs, indirect methods such as rating scales, parent interview, and from there we develop a general FBA and a BIP using what's in our Jumpstart toolbox. So general antecedent strategies that are effective for all kids, extinction procedures. And then from there, we write that we'll update it once we have more information and more data to support the hypothesized function, including, and in our reports, we always include graphs of the behavior as well as what replacement behaviors that we'll be working on. And so even those could be general at the initial prior auth. So it could be working on man training.
And even in New Mexico, the Medicaid requires that FBA be done as part of a stage 2 assessment. And it's just a limited amount of time that you have. You're basically gathering the basics. And we're reporting that basics as the beginning, and then we revise on further authorization.
And data analysis.
And data analysis.
I had a quick question, Brian. So part of the challenge, I think, in this process is one, sort of creating a document that really identifies the challenges, identifies the interventions, and gets those services in place. And you talk about getting other diagnoses, and I really wonder about the parent in terms of what that process is like for them when they get this document that says, that all of these things are going on and all of these additional diagnoses are happening. And I was wondering if you could talk a little bit about how you address sort of the intensity of what this report says in regards to the child with the parent, given that it doesn't talk a lot about the child's strengths. I was wondering if you could just talk a little bit about that.
Yep. Yeah, I think that I'm starting to get a little bit of feedback. So I'm going to try to talk through that. I don't know if other people are getting the feedback, but again, understand, let me address the first piece about strengths, that this is a medical model. Insurance companies don't care about strengths. We're playing a game. This is not about giving the best picture possible. If you want to give the best picture, then you may get denials and they may reduce services. It's simply a game, and you have to understand that. This is a very intensive document, much more so than I think most have seen, and more than what parents will receive. And the families that we've done this with, that psychiatric interview, they feel very supported. Oh, you really care about everything my child is experiencing and all the difficulties that they're having. And, oh, we're going to be able to document this. That way other people understand. That way the schools understand how severe this is. Because many times they don't. They think that this is all a figment of my imagination. The sleep disturbance is just because I don't put them to bed. And so it really is when you sit down and you talk with them about, and you know what, some of those diagnoses are painful to look at, right? And you know what, letting them know this is a game. And without this game piece, it becomes very hard to justify, particularly the intensity of services Jumpstart's providing. Other providers might get away with less for 2 hours a week. We're requesting 30 to 40 hours a week. You aren't going to get that with just autism. And that's the piece that parents have to realize.
And another piece is that we haven't got into yet is that we do put progress on the report, because that's also really important too, is that, okay, they have all these needs, now, but they are making progress. They, this service is medically necessary because before this service, this is where they are, and now that they've received the service, this is where they are. And so that piece we do go over with the parents as well, and I think that, that ending that meeting on that note is also very helpful.
Yep. Okay, so let me go down to the next area that you would want to document, and this is again where you have to really collaborate with medical providers. But some of the things that we know many of our kids have, we don't really put into the treatment plan. For example, for our kids with seizure disorders or even abnormal EEGs, documenting those diagnoses does talk to a level of impairment that we have to just effectively put in there. Any kind of GI disorders, any hearing problems, visual problems, sleep disorders, any motor, apraxia or ataxia or hypotonia, hypertonia. Even many times, sometimes you can get some TBIs or prenatal brain abnormalities, CVIs, different things like that. Putting those in there and I think one of the other things is for those that serve older populations, really specifically addressing how the onset of menses and any other problems that emerge around, or skills that need to be taught around hygiene are important to put in there. Because again, if you have if you don't have good hygiene, you can get other medical conditions there around. And so, the other thing is for kids that have, these behaviors, like an impulsive kiddo with ADHD who likes to climb on fences and falls, has a broken bone, okay, we really need to start addressing that as a medical concern because it's a danger to himself, right? So there's instances of specific medical or instances that have required medical attention that we can then say, hey, this is a problem that we need to address. And again, that's how some of those other medical conditions associated with autism, you can better document and just show the need for the treatment and the medical necessity for the treatment. And this is one that Molly was talking about a second ago. Do you want to expand on that? Around the safety concerns.
Yeah, so we have really taken a huge shift on how we, not how we write our goals, but how we display our goals and how we link them to medical necessity. And so the very few first goals that we put on our insurance reports have to do with reducing challenging behaviors, placement behaviors, and then safety concerns. We always have a goal that addresses a safety concern. And so our goals could be responding to name or inhibiting elopement or responding to simple instructions. Or it could be something like toileting trained, because that could put a child at risk if he's 12 years old and can't be toilet trained and is not toilet trained.
We actually just had a kiddo who's 5 and came out of an intensive program here in New Mexico who was sexually molested at the age of 5 and isn't toilet trained. So, that's typically how people think about toilet training, as putting a child at risk for safety. And it's just being aware of that kind of, how these typically associated behaviors or skill deficits of autism then create safety risks. And that really is important because we don't think about how defective scanning becomes a safety risk, because we think about teaching an individual skill. Well, you walk outside and it becomes an immediate safety risk. It might create wandering. Lack of environmental awareness creates the possibility of wandering in a community setting. And it's all how and this is where we can use our skills to effectively define how these deficits are creating safety concerns, right? And this is going to be one of the golden keys to expanding services or justifying services for your kiddo.
And this gets back to that the construct piece that Brian was talking about earlier is that he was talking about in the medical field, they look at certain groups of behaviors, whether it's impulsivity, attention. And so we can still work on those very specific observable and measurable behaviors, but we can tie it to something that would be better understood, like a safety concern.
Yeah. Or even above that, ADHD, right? Oh, wow, this child has autism and ADHD. I can see where this is going to be a safety concern. So let's switch over to the report and show the goals and how we're documenting that.
Getting better.
Any questions while we make the shift? Because that safety piece really is important. And that's really where you become very creative in what it is that you're doing.
So this chart here is a chart that one of our BCBAs has developed to help us keep organized, as well as really show how we're addressing the medical necessity piece within our goal. So as you can see, it has a column for the diagnoses that each goal is addressed, as well as what domain it falls under. So our domains are categorized by behavior, safety, and barriers, and then into communication and then adaptive skills. What other?
And so again, you see that immediately we're tying every single one of our goals not only to autism, but then to another medical diagnosis if appropriate. That way the reviewer realizes that this is serving multiple functional impairments and multiple clinical areas. We have, is it a current goal? We talk about progress being made. And you can just easily document it and when that goal was initiated or changed. The other thing is do you want to show the other report that you're working on?
Yeah. So let's see. Just very briefly. So this is, so the other report was, is more in progress, where this one's a little bit further along. So what Medicaid is now asking is that we visually represent the data for each goal. So based on the system that we use, I have taken the graphs of our data and I can show whether progress has been made or a goal has been mastered visually. And so if you look at this one, Johnny's tantrum refusal complied behaviors will be reduced and maintained at under 3 minutes across 10 consecutive sessions. So you see my goal line here at 3 minutes, and then you can see consecutively 10 consecutive sessions of a reduction and maintenance of the challenging behaviors. Are there questions?
So I look at that report and I think, holy crap, that's a lot of information.
It takes a while.
It does take a while, but again, this is where from an organizational standpoint, we really took the steps necessary, developed the forms to gather all the information. We implemented electronic data so that we could easily summarize data effectively. So each one of those goals takes how long for you to graph?
So it's pre-graphed.
Yeah, so I mean, but it
right, so it takes me a minute to organize the graph, copy and paste, but the data is at my fingertips, which is super helpful.
Yeah, and so making a lot of these organizational changes to be able to reflect that effectively and, more importantly, efficiently from an administrative standpoint. That way people aren't spending 2 days. How long are you spending on a report about? 2 days?
Yeah, I mean, at the same time that we update or we send new reports, we do a new assessment, a reassessment of either the VB-MAP or the ABLS, make sure that we don't have to revise anything. And so it takes me a bit longer.
But writing the report.
Yeah, but writing the report itself, it probably still takes me about 4 to 6 hours.
Yeah, so to me, a comprehensive 15-page report like this, 4 to 6 hours, is about what I would spend on a psychological stage 1 kind of report to actually write it, right? So we know we're getting a very comprehensive document. That's reasonable. Yes, it does take a lot of time to gather some of that, but if we have the systems in place to put it at our fingertips, it then it all comes back and pays dividends in the long run when we ask for these high number of hours, and the insurance company says, wow, this kiddo really needs it. I can see where this is going to make a difference. I can see the functional impairment. I can see where the progress is being made beyond what would be expected for his developmental skills. And in many ways, like we showed with Johnny on that data, I can see where his developmental trajectory has changed. And all of that comes back to then say, yep, this is pretty easy. And the other thing I'll ask and say, one last thing. That one company that I talked about being, an insurance company talked about being Satan, we submitted one of these and they just gave us everything we asked for. So maybe not all, maybe we got the right person within that organization that understood.
No, we got the wrong person.
Yeah, we've gotten the wrong person other times. But
The other,
Brian, I had a quick question. Sorry, this is Zoe. I just had a quick question about that. Can you speak a little bit, because I have found, depending on who I get as the medical reviewer, it can change a lot. Can you talk a little bit about how you negotiate that or don't?
Yep. So one thing I would say is always put in there that these services are medically necessary in your recommendation. And this is what we're requesting. They will, if they aren't wanting to approve it, they'll say, oh, well, are you willing to accept X number of hours? The answer to that is always no. This is what we've determined to be medically necessary. If you're going to change that, you need to let the family know that you are not approving this and for what reasons. But this is what me as the provider and the medical provider deems medically necessary.
And that other report that Brian is referring to, they stated that this client is not eligible for any services. So it wasn't even reducing hours. It was, this isn't, while it says that autism is covered within their policy, this is what's covered, this is actually what they have, and they've already maxed it out before their policy even went into effect. And so there's really no negotiating someone telling you that, that their policy doesn't cover it.
So, you know, I've gotten people that are very understanding and collaborative, and I got people that are just putting in their time and they just want to get to the answer of no. It depends.
Did you guys say that Johnny was originally declined hours?
No, so initially, Johnny has always been served through Medicaid, and Medicaid, it's an entitled service here in New Mexico to get, back when it started in, I think it was 09, Jen would be able to tell us better, I think it was 09, about 15 hours was covered for kids under the age of 5. And then that changed in 2015 that allowed children under the age of 5 to get 40 hours. We served Johnny for about 3 months before he turned 5. We then argued that he needed ongoing comprehensive above the age of 5.
And with that, 15 hours only included direct therapy services. There was no reimbursement for case manager supervision. So that also may play into the type of service that he's able to get now as well. There's a lot more room for additional case management, additional supervision, and support of the staff than there had been for children with Medicaid in the past.
I think one thing that we see sometimes occur as well is there will be a recommendation made by a behavior analyst for treatment, but maybe it doesn't align with the family's availability or schedule. They're not able to participate for the full recommended hours. And so I think that might be nice to kind of discuss in terms of the behavior analyst and putting in what their full recommendations are within that report rather than the family's availability to participate in treatment. So would that be something that you two would be open to discussing a little bit?
Sure, absolutely. So my thoughts on that, I think some of that, sorry, Joy, I think some of that is a California thing, right? So the regional centers mandate that families are always there during services. Is that correct?
That, but sometimes as well, the child might be participating in other treatments, and so the treatment might be recommended at, let's say, 20 or 25 hours per week, but just due to the child's schedule and family schedule, they're not able to participate. The child may not even be able to participate for that full number of hours. And so a behavior analyst then might put in the report that they're only recommending 10 hours because that's their schedule. And so I was hoping maybe we could discuss as a group why that might be important to ensure that we're always documenting what our treatment recommendations are based on medical necessity rather than family's availability.
I think that's a great question. What are people's thoughts?
I can speak a little to that. I have a client, I kind of inherited him from a different clinician, but he was only available for 10 hours a week, but obviously I would have recommended a lot more because he has no functional communication at this point, so PECS is a main goal for him. He has very few vocalizations, so he's just really a beginning learner, but he's currently receiving 10 hours of therapy. But in the summer, he'll have all this time available, and I'll have to go through the steps. I haven't done it yet, but I'll have to go through the steps to fight for more hours and then talk about how his authorization should really be higher because the need is there. It was there originally, but the report just always asked for 10 hours because that's all he could do.
Yeah. And so now the insurance company can come back and say, well, what has changed in his functional impairment that he requires more hours? Right. So it kind of puts you kind of 8-ball in a way.
Mm-hmm. Yeah. I don't have an answer.
Yeah, well, I think that's an excellent example. That's a perfect example right there, Sarah.
And many times, kind of depending for Jumpstart, I can kind of talk a little bit about what we do. Because we do see many families really ramp up over the summer, right? Because of this very issue of availability. And how do we kind of compromise that, or how do we figure that out? Some of it depends on when the renewals due, and we'll make the request accordingly. But most of the time we'll say, this is what we're recommending, get that approved, and then if we don't provide that full service, that's fine. It's just unused units. And we've never had an issue where an insurance company, when we go for the 6-month, say, oh, well, you still have, 800 units. We don't have 800 units, but you get the idea. They've never come back and said, oh, well, you didn't use that, we're going to cut back. This isn't the state or federal government where if you don't use it, you lose it. It's just, you know what, the family had other things come up and we had cancellations. So typically what we try to do is we determine what that client needs, make that recommendation, get those services, and try to figure out what the family, before we even make the recommendation, we know what the family can do. We know that there's going to be changes down the line. It allows for some flexibility during spring break when they're more available. And many times something can come up during the semester or during the year where all of a sudden the parent is no longer comfortable with having, a preschooler in school because of a restraint or something. They pull them from school, well, we can immediately increase hours without having to ask for it.
Do you mind if I actually make a comment on what you just discussed with the you don't use it, you lose it? I don't know with which insurances that's the case, but I did have actually happened to me with one client where we needed maybe 25 hours at least of services for this client. He was a very early learner, just like Sarah's learner. And we requested for this, and then because of the scheduling, because of other services, he was only receiving about maybe 12 hours a week. And when we went and sent that report, that progress report, and we requested those 25 hours because you never know, maybe you can still use them, they said, sorry, but you're not using them. So in the event that the schedule changes, then you can come back to us and ask us for more, but right now we can't give it to you because you're not using them. This was with a private insurance. It wasn't Medicaid or TRICARE.
Yeah, and I think part of that though is you can never say that they can't because they're an insurance company. They can do whatever they want, but at least you can then go back and say, hey, we've always known that this number was what was needed. I know you didn't approve it. We can do it now. Yeah, you have to make that other request, but you have a history of data there to support it, as opposed to all of a sudden, oh, well, it's always been there, but I never requested it, and it's a different argument you have to make. That's a good point, though.
So I think another topic that comes up frequently as well is that we will sometimes have insurance companies that will try to reduce the number of treatment hours based on the other services that the child is receiving. So for example, Monica, I know we didn't get to your case, but specifically the insurance company looked at the number of hours that the child was receiving in school, and other ancillary service providers were rendering services as well, I believe, and stating that between all of the services that they were going to be receiving more than 40 hours per week in total. And I believe that specifically the rationale that they provided was that an adult is not expected to work more than 40 hours per week, and so why would we expect a child to? Then there's also other insurance companies that will look at the total number of hours, and then if they hit a certain number, so if everything exceeds 50, then it will go on for medical review as well, just part of their standard process. And so who's had that experience, and what would the recommendations be when that occurs?
I mean, that was my case. So I guess I can talk a little bit about what I did. So I did send this is actually the same case, the same insurance that told me that I requested those 25 hours and they said, no, you're not using them. And so I initially wanted 20 hours, about 20 hours of recommended treatment for this progress report. And then they came back to me and they said, well, he's receiving a total of 55 hours a week of services, including school services, speech, OT, and so on. And we just had a discussion about the progress that he's already made with our services, with ABA. They asked me what were the 3 most significant improvements that we've seen since the start of ABA services. And they also very interestingly asked a lot about his communication skills and what type of communication did he use, how does he communicate at home and at school. And after a long discussion with the reviewer, it was pretty much an hour that we just went back and forth. I wasn't approved for all the 25, but I was approved for about 14 hours a week of direct services. And then they gave me actually 8 hours a month of parent training, which I didn't even request for that, but they gave me a lot of more hours for that. And that was one way that they said that they could give me a little bit more hours, but was by giving me more parent training. And so they were very nice, and they were able to collaborate with me, I guess, in that sense.
And so that's TRICARE, because TRICARE doesn't put in parent training as part of the overall treatment. They don't add those hours in. So, that's one way to work around it is, how many hours are you going to have a therapist there providing service that is also teaching the parent, and count those as separate. Don't put those into your regular total hours. So ultimately, TRICARE gave you, about 23 hours of direct service to that family, which is pretty close to what you wanted. But just know, TRICARE doesn't include parent training in the overall hours.
It actually wasn't TRICARE, but it was an insurance that was now starting to use the same TRICARE policies. They were pretty much copying them. So they went, and that's what they told me, basically. They said, we're now using the same guidelines as TRICARE.
Yep. Oh, that's a great example.
Yes.
It's starting to learn the little tricks, right? Great example.
If we request more hours, this is Rebecca Edge, we have a chart that we put inside the treatment plan of where we'll be providing the services, and if they overlap, for example, with school services, or maybe they're at their daycare or something like that, we just have it detailed inside there where and why we're requesting that many hours.
Yep.
Wonderful. Okay, we got about 5 more minutes left. Does anybody else have any questions, or like Rebecca have any suggestions that they can share in their practice? That's a big part of what we're hoping to do here, is to be able to share the information among providers so that we can learn from one another as well.
Hi, Brian. This is Arlette Bujanda with BCI in El Paso, Texas. And I have a question that is just kind of a follow-up of Kathleen's question. For when we're working specifically with TRICARE, do you have any recommendations, or have you had any experience regarding getting feedback on those other diagnoses that are not that are additional to autism? Because TRICARE for us covers only autism. And what has been your experience for them saying, well, those should be addressed in a different point or in a different setting or a different specialist? Do you have any experience with that, or any recommendations for that as well?
You know what? We don't have experience with that that I can think of.
The only thing that I would say is that all the goals we are addressing, the first diagnosis we're always addressing is autism.
Particularly TRICARE.
So we don't list any goals that don't fall under addressing the core symptoms of autism. So we haven't come across them saying you can't work on this goal because it doesn't address autism.
And I think that's that is one of the reasons we put in the co-diagnoses or the comorbidity, autism plus something. And then that way it also helps the insurance company know that this goal is addressing multiple levels of impairment.
Thank you.
Yeah, that's a good question.
That's a good question. And I think a lot of this, this is our reaction to what we've experienced. Now we're systematically addressing it. I think your question is, as insurances kind of adapt, how are we going to have to adapt in documenting what it is, the excellent work and the comprehensive work that we're all doing to get the services our families need and our kiddos need?
Yeah, definitely. I think my question was coming mainly because some cases may have, those diagnoses that you were mentioning, like regarding GI issues or just different more severe depression or things like that as well. And, it does affect definitely that impairment level that you were mentioning. So I was just wondering if you had any feedback on that. But that's really good. Thank you.
Thank you.
Wonderful. Well, I think that this has been just a wonderful discussion, and Dr. Lopez and Molly, we thank you for taking your time to share all of the work that you put into your practice, and it really is so beneficial that you took the time to share all of that information with all of us. And I think beyond what we discussed today, and we're looking at our field and ABA treatment being covered through health insurance, another piece that I think we're going to see coming out in the future is insurance covering ABA treatment for other diagnostic categories, and something that I've seen emerging through some other threads through the Autism Speaks and Autism Law Summit. And so I think that you are well positioned for that emerging area that will, I'm sure, inevitably be coming in the years to come, to be able to document the necessity and directly tie it to those goals. We do have our next guest speakers, who are going to be Dr. Sean Quigley and Dr. Courtney Burnett from the University of New Mexico, and they're going to be presenting at our next clinic on really being able to read and identify the different pieces of a diagnostic evaluation and the individual service plans, specifically in the state of New Mexico. Those are comprehensive diagnostic evaluations that really pull together the pieces of a multidisciplinary team. And so I think that will tie in very nicely following the presentation that we had today, and allow us to be able to determine what we can pull into our ABA treatment plans from those reports to hopefully be able to help document medical necessity, even if we currently do not have maybe a clinician within our practice that we're able to work with at this time. But we can discuss potentially for other agencies, how can we use the diagnostic evaluations that we're getting, the comprehensive evaluations that we're getting from these other providers, and start pulling those pieces in, similar to how Dr. Lopez and Molly are doing at Jumpstart. And then following that, we're actually going to be moving into our best practice care coordination series, and we'll be starting off with care coordination with psychologists. So hopefully that will be something that can then further this discussion and help all of us improve not only our practice, but also individually what we can maybe incorporate and discuss as we problem solve together. If we don't have something built in to an agency that we're working with, but how we could incorporate and coordinate with the psychologist on that individual level. So we thank you all for taking the time to join us